Welcome back to another video in the lecture series. Today we are going to discuss cardiogenic shock, case-based approach. I am Dr S Prakash Babu, Associate Professor of Emergency Medicine. So the objectives of today's lecture are going to be, by the end of this lecture, viewer or the student should be able to define what is cardiogenic shock, enumerate the clinical features and diagnostic approaches, and should be able to outline treatment, and also they should be able to identify a patient with cardiogenic shock when he presents to the emergency department, initiate and continue stabilization, formulate an appropriate plan for further management and disposition of the patient from the emergency department. So I'm going to discuss this lecture into first case scenarios and how you are at a diagnosis when you are presented with a case during the exam, and definition of cardiogenic shock, risk factors and the etiology of cardiogenic shock, pathophysiology of cardiogenic shock. Then I will proceed on to clinical features, appropriate investigations to either prove or disprove cardiogenic shock or for some other diagnosis. How are we going to stabilize initially and further management and disposition from the emergency department. So without wasting any time, let's get on to the case. So here is a 55-year-old male patient who is an office clerk by occupation, has presented to the emergency medicine department with a history of chest pain since 2 hours. He also complains of breathlessness and is a bit altered sensory. His past history revealed a significant for hypertension and hypertriglyceridemia with poor control. His personal history is also significant for smoking. He is currently an active smoker. His vitals at the time of presentation were a respiratory rate of 30 with a pulse rate of 130 beats per minute and BP 70 millimeters of mercury systolic. Diastolic BP is not recordable. GCS was 14/15. Now, how are you going to approach and what is your diagnosis in this case? So, patient has presented to you with sudden onset of chest pain, breathlessness, which indicate an acute cardiac event, most probably a STEMI. So, what are the risk factors for this patient to have a STEMI? Risk factors include being a male, they are prone for myocardial infarction, hypertension, hypertriglyceridemia are the modifiable risk factors in this patient, and the history gives that he is an office worker, office clerk. Office clerk means he would be sitting from 9 to 5 continuously and he would be sedentary work. Unless he does some physical activity in the evening, he should be considered a sedentary worker. So a sedentary work, you all know, can lead to acute myocardial events, and smoking is also a risk factor for the development of myocardial infarction. The patient has tachycardia, tachypnea and hypotension, which indicate shock. Altered mental sensorium indicates hypoperfusion. So based on these features, you can provisionally diagnose the patient as cardiogenic shock due to acute myocardial infarction. With this background, let us proceed into cardiogenic shock proper. So how is the cardiogenic shock defined? Any systolic blood pressure which is less than 90 millimeters of mercury, which is refractory to the initial fluid resuscitation with clinical and laboratory evidence of end organ dysfunction in the setting of a suspected cardiac dysfunction is called a cardiogenic shock. Evidence of end organ perfusion varies between clinical trials, but typically, usually it includes urine output which is less than 30 ml per hour. But urine output is a poor indicator in the emergency department. Patient will be staying for a very short duration and you will not be able to assess the urine output unless the patient presented to you with a decreased urine output. The extremities will be cold. Patient can have altered mental status due to decreased perfusion to the brain. Serum lactate could be elevated because of hypoperfusion. There is anaerobic metabolism which sets in, which increases lactate. Usually the cardiac index will be less than 2.2 liters per minute per meter square of body surface area, and pulmonary capillary wedge pressure should be greater than 15 millimeters of mercury, indicating pulmonary vascular resistance. So this is the definition of cardiogenic shock. Let us see some points on epidemiology of cardiogenic shock. Acute myocardial infarction accounts for 81% of cases of acute cardiogenic shock and is the single most common cause of cardiogenic shock. Complicates 5 to 10% of cases of acute myocardial infarction. When there is STEMI, is associated with twofold increased risk for development of cardiogenic shock compared to NSTEMI. But the mortality is high in NSTEMI patients because they will not be usually directly taken for immediate revascularization, and identification of NSTEMI is also poor. Hence, those patients have higher mortality compared to STEMI patients who are diagnosed early and treated appropriately. Cardiogenic shock has a high incidence in women because women can present with silent myocardial infarction, and most of the time you will not be able to suspect cardiogenic shock in female patients. Also, this racial variation, Asian and Pacific Island people will have more incidence of cardiogenic shock, and it is also common in patients aged more than 75 years. So different clinical trials use different definitions for cardiogenic shock. Let us have a look at them briefly. Shock trial in 1999 used the definition of systolic BP less than 90 millimeters of mercury for greater than 30 minutes, or patient needing vasopressor support to maintain systolic BP more than 30 millimeters of mercury. Evidence of organ damage in the form of urine output less than 30 ml per hour and cool extremities, and hemodynamic criteria included cardiac index of less than 2.2 and PCWP of greater than 50 millimeters mercury. IABP SOAP2 trial, which was conducted in 2012, defined as instead of systolic BP, it has taken median arterial pressure, which is less than 70 millimeters of mercury, or SBP as less than 100 millimeters of mercury, despite adequate fluid registration. At least 1 liter of crystalloids or 500 ml of colloids is said to be adequate fluid registration. Evidence of end organ damage in the form of acutely altered mental status, motile skin, urine output less than 0.5 ml per kg per hour, and serum lactate of greater than 2 millimoles per liter. EHSPCA trial, again done in 2012, defined cardiogenic shock as SBP less than 90 millimeters mercury for at least 30 minutes, or inotropes are used to maintain SBP greater than 90 millimeters mercury, and also evidence of end organ damage and increased filling pressures. ESC heart failure guidelines, SBP less than 90 millimeters of mercury with appropriate fluid registration with clinical and laboratory evidence of end organ damage. Clinical criteria in ESCHF trial include cold extremities, oliguria, acutely altered mental status, narrow pulse pressure. Laboratory include metabolic acidosis, elevated serum lactate, and elevated serum creatinine. Khamir NIH trial done in 2018. SBP less than 90 millimeters of mercury for greater than 30 minutes, or supportive intervention to maintain SBP greater than 90 millimeters of mercury. The evidence of end organ damage in the form of acutely altered mental status and SBP less than 30 ml per hour with cool extremities. So there's a list of risk factors which you need to know in cardiogenic shock, like what we explained earlier. Apart from the risk factors that can cause myocardial infarction, there are certain other risk factors which can lead directly to cardiogenic shock. So that I told earlier, people greater than 75 years are prone. Female gender are prone for cardiogenic shock. Acute or prior ischemic event associated with one of the following, like impaired ejection fraction in the previous acute event, an extensive infarct, evidence of large myocellular leak, proximal left anterior descending coronary artery occlusion, anterior myocardial infarction, multivessel coronary artery disease, with a prior medical history of previous myocardial infarction, congestive heart failure, and a patient with diabetes are prone for development of cardiogenic shock. Causes can be divided into mechanical complications, severe depression of cardiac contractility, and mechanical obstruction to forward blood flow from the heart. Mechanical complications include acute mitral regurgitation secondary to papillary muscle dysfunction or cardiac rupture, ventricular septal defect, free wall rupture, right ventricular infarction, acute aortic insufficiency due to aortic dissection, severe depression of cardiac contractility due to acute myocardial infarction, sepsis like in COVID-19 multi-organ syndrome, myocarditis, myocardial contusions in trauma, cardiomyopathy, medication toxicity like beta blocker overdose which can cause bradycardia. Bradycardia leads to development of cardiogenic shock, calcium channel blocker overdose, unstable dysrhythmias can lead to cardiogenic shock. Mechanical obstruction to forward blood flow like in valvular diseases, aortic stenosis, hypertrophic cardiomyopathy, mitral stenosis, left atrial myxoma. Finally, pericardial tamponade can lead to cardiogenic shock. Next thing you need to look at is how cardiogenic shock develops. Once there is an insult to the myocardium, either in the form of myocardial infarction or one of the other forms of myocardial dysfunction which we have discussed earlier, the dysfunction can be either systolic or diastolic dysfunction. In case of systolic dysfunction, cardiac output and stroke volume are reduced, which lead to hypotension and reduced systemic perfusion. Hypotension leads to decreased coronary perfusion pressure, and decreased systemic perfusion leads to compensatory vasoconstriction. Also, the myocardial infarction directly can induce systemic inflammatory response syndrome in the form of interleukin 6 TNF alpha and nitric oxide release. They all cause compensatory vasoconstriction. This vasoconstriction leads to progressive myocardial dysfunction. Decreased coronary perfusion pressure can lead to accentuation of ischemia. There is infarct in one place and the other part of the heart is going into ischemia. The ischemia can lead to progressive myocardial dysfunction. This sets a vicious cycle. So there is a myocardial dysfunction, reduced cardiac output and stroke volume, reduced coronary pressure, progressive dysfunction. This cycle repeats. If it is not intervened appropriately, this can lead to death. In case of diastolic dysfunction, there is increased left ventricular end diastolic pressure, which leads to back pressure and pulmonary congestion in the form of pulmonary edema. Pulmonary edema leads to hypoxia. Hypoxemia accentuates the ischemia, and again a vicious cycle is set up. So if you have intervened with revascularization therapy early, there is relief of ischemia and there is a good survival with quality life. This is the pathophysiology how cardiogenic shock develops. Let's come into the differential diagnosis. What are the things that you need to consider when you are seeing a patient with shock? But until now you are not clear whether it is due to cardiogenic shock or any other form of shock. Usually acute pulmonary decompensation like in chronic obstructive pulmonary disease, exacerbations, carpulmonale, massive pulmonary embolism can have acute presentations which mimic cardiogenic shock and they can potentiate cardiogenic shock. Some form of distributive shocks like sepsis, anaphylaxis and neurogenic shock can present with features suggestive of cardiogenic shock. We need to differentiate. We'll come to it later how you will differentiate cardiogenic shock from other forms of shock. Then hypovolemic shock either due to hemorrhage or severe dehydration and fluid loss. Dissociative shock because of toxins or drug abuse can mimic cardiogenic shock. Clinical features. There are some features which suggest right heart failure. There are some features which suggest left heart failure, and there are some common features. Common features usually include that of hypoperfusion. What are the features suggestive of right heart failure? Right heart failure is usually a chronic disease which progresses and gets decompensated and then lead to cardiogenic shock. lower limb edema, sacral edema, hepatomegaly, that is increased jugular venous distension, regurgitant murmur in the tricuspid area indicates right heart failure. Those suggesting left heart failure include signs of pulmonary edema like lung crackles, respiratory wheeze, displaced cardiac effects, and left-sided heart murmurs, which indicate an acute valvular decomposition. Shade features, as I told, they are due to hypoperfusion, usually cool periphery stenosis, orthopnea, and delayed capillary. So there are different forms of shock: cold and wet shock, dry and cold shock, wet and warm shock. Cold and wet shock occurs with cool extremities and signs of pulmonary congestion, which reflects a reduced cardiac output. Dry and cold shock indicates reduced cardiac index and increased systemic vascular resistance with normal PCWP. Wet and warm shock represents a systemic inflammatory response syndrome reaction in conjunction with myocardial infarction and is associated with a higher incidence of sepsis and mortality. So now let us go into how you are going to evaluate the patient. What are the historical points you need to collect specifically from a patient with cardiogenic shock? In another video, I have discussed how you need to collect history from a patient presenting to the emergency department. Here I am focusing only on the crucial points which you need to collect from a patient whom you suspect to be a cardiogenic shock specifically. Most of the time, patient will be in altered sensorium and they will not be able to give you the complete history. Family, EMS personnel, and previous medical records will be helpful in knowing what has happened to the patient in the past, especially if the patient is a known patient of CAD. Usually, the presenting complaints will be of that of the underlying disease, like a right heart failure or a valvular heart disease or acute myocardial infarction. Most of the patients will present with breathlessness, chest pain, and are weakness because of the shock. It is a generalized weakness, not a specific area weakness. Collect thorough history to exclude other causes of shock. So you know the differential diagnosis, other causes of shock like sepsis shock, anaphylactic shock. You will know by asking the patient whether the patient had fever before presenting with this, or you can ask the attendants whether the patient has fever, or recently he had taken any drugs, or is it sudden in onset, there is any bee sting or any exposure that can cause anaphylaxis. Those history you can ask. History of pre-existing valvular disease, recent illnesses, hypercoagulable states, substance abuse like cocaine and amphetamines, which can lead to cardiogenic shock because of tachycardia, should be asked, and all the information about the risk factors which I quoted earlier should be collected in every patient. Once you collected the history, you need to perform a physical examination. Cardiogenic shock is usually characterized by hypoperfusion, and you will see all the signs of hypoperfusion. Hypotension may not always be evident. Like in suppose a patient is a previously hypertensive patient, his baseline BP will be set at a higher level, and you will not find hypotension as per definition in this patient. You will not see a BP of less than 90 millimeters of mercury. Suppose a patient's baseline BP is set at 140 millimeters of mercury by using drugs, and now he is presenting with 120 millimeters of mercury or 110 millimeters of mercury. Even though by definition it is not less than 90 millimeters of mercury or 100 millimeters of mercury, still the patient will have hypoperfusion because his baseline BP was higher and his system was acclimatized for that higher BP. Now he has lowered BP. The difference of 20 to 30 millimeters of mercury makes a lot. And you will usually see sinus tachycardia, and pulse pressure will be usually less than 20 millimeters of mercury because of vasoconstriction. Diastolic BP is higher and systolic BP is lower. You will have a narrow pulse pressure. Tachypnea and respiratory failure are evident. Raised JVP and a hepatojugular reflex will be evident in case of right heart failure. Peripheral edema suggests pre-existing heart failure. Patient will be profusely sweating due to sympathetic activation, altered sensorium and reduced urine output due to hypoperfusion. Lung examination reveals signs of pulmonary edema in the form of extensive rales or crepitations. The apical impulse is normally felt. It is usually an acute event. There is no pre-existing cardiac remodeling, so the apex is in normal position. If the apical impulse is shifted laterally, that means there is a chronic heart condition, especially the left ventricular hypertrophy due to any valvular disease. Chronic cardiac remodeling is suspected. A new onset murmur usually indicates an acute mechanical complication. So once you have examined the patient, you need to order investigations. Cardiac catheterization is the definitive investigation. It can both diagnose at the same time. It can also treat the patient for acute myocardial infarction, blockade in the coronary system. ECG is the first and foremost investigation that should be done, and it should be done and interpreted within 10 minutes. There is a misconception that ECG should be done within 10 minutes. That's not the case. You should do an ECG, and an expert should interpret the ECG within 10 minutes in a patient presenting with acute myocardial infarction or side stroke of acute myocardial infarction, cardiac chest pain. ST segment elevation or ST segment depression, which indicate infarction and ischemia, and non-ST segment deviation can be seen in the ECG. And also there can be evidence of either bradycardia or tachyarrhythmias. A 2D echo is the definitive in identifying acute myocardial infarction and all its complications, including the mechanical complications and also other kinds of cardiogenic shock like pericardial effusion, myocarditis, things. You can do a transthoracic or transesophageal bedside 2D echo. 2D echo, bedside 2D echo should be followed by a complete echo study in the clinic once the patient is stabilized. Obtain a bedside chest X-ray in all patients and look for any evidence of pulmonary edema, any evidence of viral or interstitial pneumonia, and a focus in the form of EFAST, rush protocol, blue protocol can be used to diagnose other kinds of shock, and also it can prove presence of cardiogenic shock if you see feature studies of wall motion abnormalities and also the mechanical complications. And not only focus is used to diagnose, it can monitor response to the therapy. If you are doing serial focus examinations, you can monitor response to the therapy. If there is no response, you can change your line of treatment. And you need to, along with imaging, you need to do some laboratory investigations. Complete blood counts usually will tell whether there is an inflammatory response. Complete metabolic panel, including serum electrolytes and lactate. Serial troponin assays in case of suspected M-STEMI. N-terminal BNP for acute decompensated heart failure. ABG for looking for hypoxemia, hypercarbia, and lactic acidosis can be done. Coming to the hemodynamic monitoring in a patient with cardiogenic shock, the goals are to produce stable vitals and adequate tissue perfusion. Invasive monitoring is preferable because non-invasive monitoring is obsolete when there is severe vasoconstriction. Non-invasive monitoring will not give you an appropriate values for the vitals. PCWP or CEP should be used for monitoring cardiac output, cardiac index, and left ventricular end-diastolic pressure. Continuous blood pressure monitoring with an arterial line, telemetry, continuous pulse oximetry, temperature, respiratory rate, and urinary output are rudimentary parameters to monitor. And mixed venous oxygen saturation can give you an idea about cardiac output. So once you have diagnosed cardiogenic shock, you need to stabilize the patient. Sometimes you might need to resuscitate the patient. If the patient is in pre-arrest condition or already in cardiac arrest, use ACLS protocols for the resuscitation. First and foremost is IV fluids. Definitive method of volume status assessment and adequacy of registration is right heart catheterization. Alternatively, you can use Pazzo leg raising test. Without giving fluids, you can check whether the patient is fluid responsive or not. If hypovolemia is present, conservative boluses of crystalloids of 250 to 500 ml are reasonable while the patient is being stabilized for cardiac catheterization. Oxygenation and ventilation, we should target a saturation of greater than 90%, preferably 92 to 94%. Non-invasive ventilation or invasive mechanical ventilation can be used to optimize oxygenation. Low tidal volume ventilation is lung protective and improves pulmonary dynamics. Monitor urine output and administer fluid boluses in the absence of pulmonary congestion. Correct rhythm disturbances, electrolyte abnormalities, and acid alterations. Identify and treat cause early. Administer antiplatelet agents early in case of acute myocarditis. Next comes the vasopressor support. Titrate to a median arterial pressure of 65 millimeters of mercury. Norepinephrine and epinephrine are the first line vasopressors. Vasopressin can be used as first line vasopressor if it is due to less pulmonary vasoconstriction. Pulmonary vasoactivity can be modified by inodilators like phosphodiesterase 3 inhibitors or nitric oxide. Definitive treatment includes early revascularization with percutaneous cardiac intervention. Thrombolytic therapy is not effective in case of cardiogenic shock. Survival from cardiogenic shock is highest with emergency coronary intervention, followed by intra-aortic balloon pump combined with thrombolytic therapy. When the patient is not improving with vasopressors, you might consider mechanical circulatory support devices. Options for acute percutaneous mechanical circulatory support include IABP, intra-aortic balloon counterpulsation, axial flow pumps to the left atrial to the femoral arterial ventricular assist devices like Tandem Heart and ECMO. IABP is the most widely used MCS. IABP provides hemodynamic support by decreasing the afterload, which lowers myocardial oxygen consumption and increases the diastolic blood pressure, which augments coronary perfusion. Percutaneous left ventricular assist devices used only as a bridge to transplant. Extracorporeal membrane oxygenation can provide support until percutaneous coronary intervention can be performed or until the heart begins to recover after intervention. So this is how IABP inserted. During systole, there is deflation of the intra-aortic balloon pump. There is decreased afterload, decreases cardiac work, decreases myocardial oxygen consumption, and increases cardiac output. During diastole, there is inflation of the balloon, which augments the diastolic pressure and increases the coronary perfusion. Possible scheme for selection of patients with cardiogenic shock complicating acute myocardial infarction for left ventricular assist devices. Patient with acute myocardial infarction and cardiogenic shock, there is no mechanical complication. PCA of infarct-related artery with multivessel PCA, inotropes and fluids with IABP are preferred. There is adequate support. You should plan for weaning. There is no adequate support. Percutaneous short or mid-term left ventricular assist devices can be used. Look for recovery. If yes, plan for weaning. If no, implantable left ventricular assist devices, transplantation can be done. There are mechanical complications due to acute myocardial infarction. PCA of the infarct-related artery, multivessel PCA, inotropes fluids along with IABP. Adequate support, yes, go for a definitive surgery. If there is no adequate support, percutaneous short or mid-term left ventricular devices can be used. Percutaneous left ventricular devices simply useful for patients with cardiogenic shock, not responding to standard therapy and IABP. They are used as bridge for recovery. Percutaneous cardiopulmonary bypass consists mainly of blood pump and oxygenator. 16 to 18 French arterial cannula in the descending aorta and 18 French venous cannula advanced into the right atrium. Lower limb ischemic complications, requirement for perfusion is lack of direct LV unloading, increased afterload, and a limited support time are the drawbacks for percutaneous cardiopulmonary bypass. It is used for patients who collapse in the cath lab during the procedure. Axial flow pumps positions across the aortic wall to provide active support by transvalvular LV assistance. The pumping system consists of an axial blood flow pump, which was positioned in the aortic arch at the descending aorta, an inlet cannula, and a drive cable in a polymeric sheath and motor will be there, and they will assist in increasing the cardiac output. So these are some of the important clinical trials in cardiogenic shock trials, which we have discussed already. So this ends the lecture on cardiogenic shock. Hope when you are presented with a patient with cardiogenic shock, you can manage, at least initial management can be done appropriately. Stay focused on your destination, even if your path may seem stormy today. Tomorrow it might be better. Thank you. Don't forget to subscribe and share the videos. Thank you.